السلام عليكم. أنا دكتور منال طايل، أستاذ روماتولوجي وكلينيكال إيمينولوجي. أولا كل سنة وانتم طيبين، رمضان كريم عليكم. النهاردة هنتكلم عن حالة لوبس، وحالة اللوبس اللي معانا النهاردة أختنا ياسمين. ياسمين طبعا انتم you are aware about ياسمين، لأن احنا we have met ياسمين in the spot diagnosis of systemic lupus. Yasmin is almost 28 years old, female. She's married and she has one child. She got a previous history of 2 abortions. One was a spontaneous abortion and the other one was induced abortion, because the second abortion was done because of the impaired renal function, so the doctors allow her to do a therapeutic abortion. Yasmin also has a history well known to us, that she has a history of repeated DVT of the lower limbs, alternating between the right lower limb and left lower limb, and the DVT has been counted up to 12 times of DVT. Actually, she got also a previous single history of pulmonary embolization without a significant pulmonary arterial hypertension. Yasmin is also known to have an impaired renal function, and when we asked her about her renal states, she told us that she has previously proteinuria. بكلام العيان بتقول أنا عندي زلال في البول بتاعي بيرغي, and she has also a lower limb edema, extensive, unequal, and we have demonstrated this in the last session. She has also previous history of puffiness of the face and oliguria at some times. Now she is controlled by treatment. Let us stress today about certain manifestations of lupus. Actually, and unfortunately, we don't have available patients with active lupus skin lesions. That we have mentioned in the last time, that it should be a malar rash in the form of eruption over the malar area and the bridge of the nose, and this eruption may extend to affect the chin of the face, the V-shaped area anteriorly and the V-shaped area posteriorly. When this lesion is considered to be active, the patient usually the lesion is red, erythematosus, itchy, and usually is a photosensitive lesion. And when we asked Yasmin about what she means by photosensitive lesion, she told us that the lesion either appears de novo or the lesion got activation, or more erythema, more scaly, more itchy when she has been exposed to sun. This is one of the first lesions that Yasmin got, and she told us that this was one of her presentation since 12 years ago. Also, we asked Yasmin, please look to the camera. When we asked Yasmin about mouth ulcers, open your mouth. طلعي افتحي بقك للاخر, طلعي لسانك بره, اعوجي يمين, اعوجي شمال, ارفعي فوق. Okay, I'm looking for the presence of ulcers, oral ulcers, and also I did like that, up and down to the lips, to see if there is oral ulcers or not. What has been mentioned as regard the oral ulcers of lupus, that the ulcers are not painful, small sized ulcers based, usually opposite the molar area, over the molar area in the mucosa of the mouth. But there is also ulcer that may extend to the pharynx and to the esophagus, and also ulceration of the mucosa of the nose. In addition, there may be vaginal ulcerations. Usually, by definitions, the ulcers are detected by the physician, and usually it is not a complaint of the patient, because these ulcers are considered to be painless ulcers. Only it got pain when it is infected. Don't forget that if you have a patient with oral ulceration, that we have a lot of causes, not only lupus, it may be Crohn's disease with inflammatory bowel, it may be pemphigus, it may be lichen planus, it may be just simply stress ulcers or peptic ulcerations, second to dyspeptic manifestations. Behçet disease, one of the most common causes of ulcers. Don't forget the causes like Stevens-Johnson's disease, hepatitis C virus may be associated with oral ulcerations also. We have a lot of long history. In our patients, don't forget methotrexate. Methotrexate, if it is given without folic acid, it presents the patient may be presented to you with extensive oral ulceration. He usually is in a very bad situation. Toxic oral ulceration, secondary to methotrexate, is one of the features of folic acid deficiency. This is as regards the oral ulcers. If we look for the hair, the last time you have seen the hair of Yasmin, so I will not repeat it. If you look to the hands joints, we may have what we call it non-deformable, non-erosive joint manifestations. If you look to the hand of Yasmin, it is totally free, totally free. There is no hyperpigmentation, no nail dystrophy, no ulcerations, no temperature changes, the temperatures are normal, no deformities could be seen, even the muscles are not wasted, no vasculitic spots, not pale, no evidence of Raynaud's phenomena. What about the Raynaud's? Raynaud's is lupus is one of the conditions, the autoimmune disease that is commonly to be associated with Raynaud's. Although the most common is systemic sclerosis, but lupus is one of the common. When Raynaud's is present in a lupus patient, it's called Raynaud's, secondary to an autoimmune illness. Actually, if the patient has Raynaud's, the patient comes to you telling you, Doctora, please, I have on exposure to cold, I have my fingers turned white turn، عشان كده بيقولوا بتبقى بيضة، بتبقى بكحلة، يعني اللون بتاعها أبيض. I have my fingers white, and then it turns bluish, and lastly it turns what we call it red. These are what we call it the three color change phases of Raynaud's. Raynaud's is an abnormality of the neurovascular stimulation, neurovascular response in response to cold weather. So the most essential phase of Raynaud's is the white coloration. And if you put Google image and ask for Raynaud's phenomena, they will give you white fingers. Raynaud's may start in all the fingers or in one finger and then proceed to affect other fingers. Raynaud's may affect hands, may affect feet, may affect the nose. Also, moreover, there may be Raynaud's of the coronary vessels, Raynaud's of the renal vessels. So Raynaud's is a very important situation that you should look about it. Severe forms of Raynaud's may be associated even with ulcers. It looks like vasculitic ulcers. Raynaud's, to be diagnosed and to be differentiated from vasculitis, we should do what we call it a capillaroscopic examination to see the changes of the blood vessels associated with Raynaud's that can be differentiated from cases of vasculitis. Raynaud's, for treatment, we have to ask the patient to stop totally avoid exposure to cold weather. We have also to ask her to put gloves and stocks if needed, and not use the refrigerator, not put her hands on the refrigerators, and we have to give her vasodilators and also sometimes antiplatelets, and even in certain conditions surgical deprivation of some of the fingers may be needed, or cutting, or what we call it sympathectomy to the affected areas in order to stop the advanced cases of Raynaud's. We have mentioned that the joints are non-deformable, non-erosive. Arthralgia or arthritis may affect the hand or the feet, but we may have some inflammation with swelling and fusiform fingers sometimes. This patient has no fusiform fingers, but sometimes you can see that this middle, the proximal interpharyngeal the proximal interpharyngeal joint is swollen and tender, but here it is neither swollen nor tender. The only deformity that has been demonstrated in lupus patient is what we call it Jacques arthropathy, which is a picture simulating swan neck deformity, but it is totally correctable. So the patient may have a picture like that, but when you stretch the fingers, it is totally normal. This is because of the ligamentous laxity. Actually, Jacques arthropathy has been first demonstrated in patients with rheumatic arthritis, with rheumatic fever. When we have some knee effusion, elbow effusion, whatsoever, we can have an arthritis of any joint that may have. As regards Yasmin, we have to ask her about her chest, if she has a pleuritic chest pain or not, and if this chest pain was associated with fever and then the pain disappeared. This is what we call it pleurisy and pleural effusion. There may be also central or precordial chest pain in cases of pericarditis and may turn into pericardial effusion, but don't forget that cardiac tamponade is very rare in cases of lupus patients. Don't forget also that the bilateral pericardial effusion, bilateral pleural effusion and pericardial effusion are considered what we call it serositis, and serositis in lupus patients associated with increased level of ESR and CRP, and this is one of the conditions of lupus that CRP is elevated. Because we know that in lupus patients, usually ESR is elevated, but normal CRP, except in cases of serositis and the presence of underlying infection. So we may have bilateral pleural effusion and pericardial effusion. Arthritis is considered part of, it is not, knee effusion is considered part of the serositis, and ascites is not considered part of the serositis, and usually if ascites is present, we should look for a localizing factor. If you go down to the abdomen, you may have an enlarged kidneys in case of nephrotic syndromes. You may have small-sized kidneys. You may have evidences of internal mesenteric vessel occlusion or mesenteric vessel vasculitis with disturbed level of movement of the intestine, with evidence of intestinal obstruction, and this is considered one of the emergent situations. Rarely the patient may have pancreatitis with the whole blown picture of acute abdomen. If you look to the nervous system can be also affected in lupus patients, and you may have affection of the central nervous system or the peripheral nerves, and actually in the criteria of lupus they have mentioned 17 features of lupus CNS, what we call it neuropsychiatric lupus, and they said that if your neurologist or psychologist demonstrate or diagnose one of the following items, this is considered a criteria of the diagnosis of lupus. This has been included a lot of diseases, mainly cerebral vasculitis, CNS vasculitis, cognitive dysfunctions, optic neuritis, peripheral neuritis, mononeuritis multiplex, mononeuritis. There may be also cranial nerve neuropathies. Also there may be cerebrovascular strokes, transverse myelitis, Guillain-Barré syndrome, in addition to the schizophrenia, the psychological manifestation like the schizophrenia, and the different items. Don't forget the epileptic fits. Actually, our patients may be referred patient from the neuropsychiatric department because of the diagnosis of unexplained epilepsy, and I remember our professor who said that an epileptic fit in a young lady without a history of trauma should be diagnosed as lupus till proved otherwise. So if you have a patient, a young-aged patient presented with convulsions and she has no evidence of infection or evidence of head trauma, please ask for ANA. Also, part of the examination of the lupus patient should be the vascular system. Search for the arterial insufficiency, search for the venous occlusions that may be of the peripheral vessels or central. Vasculitis could be presented as a form of coronary vasculitis and myocardial infarction. There may be mesenteric vascular occlusion, retinal vessel vasculitis, retinal artery occlusion, and so on. Also, can we stop now? ممكن نوقف شوية.
تمام أنا كده.
أنا مش عارفة الوقت قد إيه.
مش عارف الوقت كده قد إيه؟
فاضل لي مثلا.
إحنا كده صورنا ربع ساعة.
ربع ساعة؟ طب أوكي. هنكمل. أوكي. As regards the kidneys, actually 50% of lupus patients presented with kidney manifestations, and lupus nephritis is the presenting features in almost 50% of the patients. So it is very important, and according to the criteria for the lupus, we have to know that either we diagnose it as part of the clinical lab diagnosis in the form of proteinuria more than 0.5 gram per 24 hours and active urinary cast or sediments. This is one way of diagnosis of renal involvement. The other arm by which we can diagnose is that a patient presented to you with renal manifestations and with ANA or double-stranded DNA positive, and you can find nothing abnormal with any other body system, so you ask for a renal biopsy and it is proven to be lupus nephritis. So this is the second arm of using SLIC criteria. The patient with renal problem can be presented with as a manifestation of nephrotic syndrome, a manifestation of impaired kidney function, even hypertension only, or the patient may be presented with the picture of CKD. With this, usually it depends upon at which stage you have seen the patient of her kidney affection. Is it simply grade 2 or 3, or we pass into the membranous phase of grade 4, or it is a sclerotic phase in the last phases where the kidneys are small sized. Your patient may come because of hypertension, because of the generalized edema, because of the oliguria, because of the frothy urine, because of the abdominal pains, because of the repeated urinary infections, because of the manifestations of renal impairment like the vomiting, the convulsions, the electrolyte disturbances, the muddy face, the severe anemia, the body aches, and so on. So we have variable grades of presentation for renal affection. Usually we are in need to follow the patient by urea creat. We have also to do what we call it protein creat ratio in order to evaluate the amount of proteins in her 24-hour urinary collection. And don't forget that we may use C3 and C4 when usually are consumed, they are low. And also if you are in a good center, you may have the availability to perform C1Q test in order to see, because it is one of the markers of renal affection. And it is markedly consumed in patients with lupus nephritis. As regards the kidneys affection, it is one of the major organs that may cause us increasing it, what we call it the damage index of lupus patients, not only active, it may pass into state of damage. And I want to take the chance now to revise with you how to treat lupus nephritis. Besides the treatment of the comorbidities like the hypertension, the diabetes, and the vitamin deficiencies and the anemias, the infections of the urinary system, we have to attack the lupus nephritis itself. We have, usually they treat lupus nephritis or they deal with it as if it is a case of a malignancy by induction followed by maintenance. The induction should always be by, if we are past the stage of 3 or 4, we have to give what we call it pulse steroid therapy in the form of 1 gram methylprednisolone for 3 successive days. This is during giving this methylprednisolone, don't forget to follow up her diabetic state, her hypertensive state, and electrolyte state. After these 3 days, we have to continue the induction by one of two ways. Either by oral tablets in the form of Cellcept or what we call it mycophenolate mofetil. It is available in the market in the form of 500 milligram or 250 milligram tablets, and the induction is usually by 2 to 3 grams, means by almost 6 tablets per day. This mycophenolate mofetil has the disadvantage of being expensive, but it is an oral, the compliance is good, and it does not cause gonadal failure. It protects the gonads. And the mycophenolate mofetil has the disadvantage of bone marrow failure and also the diarrhea and gastric upset. If you, this is an arm, so it's better to choose the Cellcept or the mycophenolate mofetil for the ladies who are in need to protect their gonads. If your patient is older enough or failed the Cellcept, go to use what we call cyclophosphamide or Indoxan in 1 gram per meter squared surface area through an intravenous line in the hospitals. And this Indoxan has the advantage of being less expensive, very cheap, and rapid, very highly effective, but it has a disadvantage of producing bone marrow failure, gonadal failure, and don't forget cystic hemorrhagic cystitis. Hemorrhagic cystitis means that the metabolite of the Indoxan, as it is excreted to the kidney, is passed to the urinary bladder. It causes destruction of the internal surface layer of the urinary bladder with extensive bleeding. So all the time, put the Indoxan in an infusion slowly. Ask the patient to follow her urine color. Ask the patient to be well dehydrated 24 hours before and even during the infusion. The Indoxan is very important because it is cheap, available, and it is highly effective. All the time, before giving the Indoxan, you should monitor the patient for the fever, for the severe anemia, for the urinary tract infection or any source of infection, and if okay, go and give her the Indoxan as an infusion. Usually we follow what we call it the Eurolupus protocol, where we give the Indoxan every 2 weeks, half the dose, which is 500 milligrams, and for 6 infusions, and then we shift the patient to the mycophenolate mofetil. This is the induction. Then it is followed by maintenance, which is maybe by either a mycophenolate mofetil or Imuran, or and may add to them also the what we call cyclosporin to reduce the proteinuria. Don't forget that all patients are on hydroxychloroquine in order to, it is one of the most important medications used for lupus patients, and it is important as an immune modulator. It is given in a dose of 5 milligram per kilogram body weight with a maximum dose of 400 milligram per day. Don't forget that it can cause a lot and a long list of side effects. The most common of it, it's not, sorry, the most famous, not the common, the most famous of it is the retinitis. I hope that I have resumed the treatment protocols for lupus patients, and I will be ready to receive your questions by any way you need it. Thank you.